I understand that I am the only obstacle between the end of the conference and the coffee and the networking which is happening outside. So I'll try to finish it as soon as possible and very briefly. See, I'm not going to talk about any hi-fi AI or something. We are all oncologists. Yes, AI is evolving in oncology.
You need not
but still,
compromise. You take your own time because
right.
you have your own
No,
rights.
I'll take 20 minutes, sir. I'll just take 20 minutes, not more than that. So, so my topic is more about what we are doing in ALK positive non-small cell lung cancer. At the outset, I would like to thank the organizers, chairpersons, Dr. Shikhar, and Pfizer team for this wonderful opportunity. So, what I'll be just going through in the next couple of minutes is about lorlatinib and how it has changed the entire spectrum of management of ALK positive non-small cell cancers. So this is a brief history of what has happened in the ALK positive subset. So we have had the first discovery of EML4 ALK, the mutation in approximately around 2007. Then arrived crizotinib, ceritinib, alectinib. Now we have the third generation molecule, which is the lorlatinib. So now, why was it important that newer and newer molecules be identified? See, most of these ALK positive non-small cell lung cancer, even in our OPD, they tend to be younger. They're almost around, the median age is around 50 years of age. Most of them are non-smokers, they're female, and they do not have any major risk factors as of such. And approximately around 20 to 30% of these patients, they have some sort of intracranial metastasis. See, having intracranial metastasis in a carcinoma lung is a bad thing. So now if you have some targeted therapy which can control this is a very good thing for the patients. And the prior first generation and second generation ALK TKIs, the problem with that was most of them had acquired ALK resistant mutations, or they would have further CNS metastasis during their course of therapy. Hence, there was an additional need for newer ALK TKIs that prevent the emergence of resistant mutations. And in any oncology, only around 75% of the patients take second line treatment because 25% get dropped due to various reasons, either both the health related or financial related toxicities. So it's important that you use the best drug upfront. So this is the same thing. And now how do we decide what to choose whenever we choose a drug for ALK positive non-small cell lung cancer? So in any other drug, as per any other drug, these are things that we look at. We look at the response rate, the toxicities, the financials, the overall and progression-free survival. So now what is the importance of this particular molecule, lorlatinib, which is actually a molecule which was introduced by the Pfizer company. So this has entirely changed the management of ALK positive metastatic lung cancers. So it was, the CROWN is a trial, the name of the trial. This is a phase 3 randomized trial where they have randomized people with ALK positive non-small cell lung cancer of a good performance status. They could have brain metastasis at baseline. They have compared lorlatinib versus crizotinib. The dosage of lorlatinib used here was 100 milligram OD as compared to 250 milligram BD. The primary endpoint here was progression-free survival. So here again, at the median follow-up, the progression-free survival was grossly increased. It was not reached in the lorlatinib arm compared to 9 months with crizotinib. The hazards were impressive. It was only 0.28. So this is a brief cross-trial comparison. I understand that this is a cross-trial comparison, but across major trials, what we can see that the PFS even with alectinib was only 34 months, but here it was not reached with lorlatinib. Now, what is the efficacy analysis, which is very interesting. See, this kind of Kaplan-Meier curves are not seen with many molecules in oncology. See, you can actually, this is called as a truck Kaplan-Meier curve, where you can pass a bus or a truck between these two curves. So almost, if you, as compared to crizotinib, at the end of 5 years, only 8% patients were still continuing the drug compared to 60% of patients receiving lorlatinib. So this is one molecule which has changed really the management of non-small cell lung cancer. Even irrespective of the presence of baseline or without baseline brain metastasis, it showed efficacy. So there was a gross difference of around 50%. Even the median progression-free survival, there was a huge difference. The hazards were almost around 0.24, which was statistically significant.